Computer, okay. All right, so a lot of things I want to just remind you of, and then we're going to finish the foot and ankle chapter. How's everyone doing today?
Pretty good.
Pretty good. Well, I'm doing fantastic, as always, because I'm here with you fine folks. Are you buying it? I mean it. All right, so before I talk about the exam coming up and some other things, I just emailed Dr. Stapleton to ask about the final, because I'd like to know when it is. And he sent me the final exam schedule, but I don't know how to read it. So I'm going to share my screen. Maybe one of you can help me understand how to read this thing. So Dr. Stapleton said that it looks like our final is Thursday, May 6th, 3 to 5.
I think it's 12 to 2 because our regular class is 2:30 to 3:50.
So how do you read?
So our classes are Monday, Thursday, 2:30 to 3:50. So that's like the normal time. And then you follow it over for the final exam.
Okay, so maybe he was looking at the lab time, but that's not, our lab goes 4 to 6, but that's not even the right. So you think it's, okay. Anybody else have any thoughts? Do we agree with this? I will confirm with him, but it's looking like Thursday.
I agree, yeah.
Okay, so it's looking like Thursday, May 6th, 12 to 2. And I did confirm with him that because our lecture has been online, the final exam will also be online, which kind of stinks because it's a long exam. It's not fun to take online. All right, so let's pencil it in. It looks like our final exam is going to be Thursday, May 6th, 12 to 2 p.m. Thank you for helping me decipher that. I will give you more information about the final exam next week. Usually my final exams are 125 multiple choice questions, but 125 I think is a lot to do online. So I haven't quite made a decision, but what I'm thinking is, I'll shorten it to 100 questions, which is still not short, but I think it's more doable.
Still all multiple choice?
Yes, so I know for the regular unit exams, we've had some short answer, but for the final exam, it will be all multiple choice. It will be cumulative. It usually breaks down to 8 or 9 questions per chapter, and the questions will be given in order. So, when you first start, numbers 1 through 8 will be on our first chapter of the semester. Then questions 9 through 16 will be on the second. So I like to order it because I don't think it's fair to mix them all up and then your mind, I want you to be able to focus on one chapter and answer those questions before moving on to the next. Yes, so I think I'll run it like we have our regular unit exams. So you'll log on to Zoom with your pretty faces, and then you'll take it as I watch. But I wanted to make sure I got the date because I know everyone's got things going on. So I will confirm it, but right now it looks like Thursday, May 6th, 12 to 2 p.m. Questions? Cross that bridge when we get to it, right? Okay. All right, so I got some other reminders and I've put everything on Moodle. So let me share the screen because I just uploaded it. So let's go to Moodle. Let's get out of this schedule that I don't understand. Okay. So you guys saw the pictures I sent out Monday. My cat Oscar totally photobombed things. This one is funnier, I think. Did it make anybody smile? Come on.
Yeah, I did. I liked it.
Oscar
Is he a chunky kitty?
No, he just looks chunky. The camera adds 10 pounds.
He looks like my cat. My cat used to be 30 pounds.
I'm sorry, did you just say 30 pounds?
Yeah, he was a big boy. And then, like a month ago, he got diagnosed with diabetes. Well, he was like losing a bunch of weight, and we thought it was a diet, but it wasn't. He had diabetes. But he's good now. He's on insulin.
Yeah, Oscar's from our backyard. He's his mom is a Bengal kitty, so he has like Bengal spots on his belly, and then his dad has the tiger stripes. Anyway, thought that was funny. All right, so you know, when I see you next, Monday, April 19th, we have our 4th lecture exam. So I wanted to put this information on Moodle so you would have it. You know what to expect by now. This exam is going to be on the lower extremity, about 45 questions, multiple choice and short answer. I have written down here 65 minutes. If you need longer, I'll probably be okay with it. Next Monday, there will be nothing else in lecture aside from the exam. If you have questions, email me, send me a message on Remind. Okay.
I've got pushed back to 4:30 on Monday, right? Right?
Yes, and I'm going to bring that up also, but you are correct, Jake. For those of you in the Monday lab section, for those of you coming to lab next Monday, we will start the lab at 4:30 because I don't want you to feel rushed after this lecture exam. So next Monday, every other lab will start as usual at 4 p.m., but this coming Monday only will start at 4:30. So I put down some important due dates because I just want to make sure that everyone's clear. I know I said this, but just to be clear, we have our lecture exam next Monday. Boom. Your cumulative lab workbooks, as I said already, they're due next week in lab. They are due at the beginning of lab. So when you walk into lab next week, I'm just going to have a pile and you'll just walk in right at the beginning and you'll give me your hard copy, not electronic, please, hard copy. So if you have lab on Monday, it's due Monday at 4:30 in lab. If you have lab on Thursday, it'll be due Thursday at 4. Don't forget it in your car, double check. If you forget it at home, I'm not going to accept it. So just double, triple check. Reminders on your final lab presentations. Your final write-up and the tables is due whatever date and time you present. So for some of you, your written summary and your printed out tables are due next Monday at lab. Some of you are due next Thursday. Some of you are due the following week. I would like hard copies. On Moodle, there is a document that shows when you are presenting. If you come to lab and you're not ready for your presentation, you'll get a 0. Remember, I like the presentations to be 10 minutes, no longer. Make sure you practice your presentations. You can have little note cards. That was one of the questions. Practice it at home for time. If you go over, I will stop you. No points will be deducted if you go over, but you may not be able to get in everything that you need for the points. Or if you end too early, I'm going to deduct points. So I'm giving you that 9 to 10 minute range. I mean, if you're like 30 seconds over, it's fine. you know what I mean? But please practice the timing. Even on the lab days that you're not presenting, you still have to be there. Remember, you're going to serve as the class, or you're going to take part in the activities. And just a reminder, only next Monday we'll start at 4:30, not 4. Also on Moodle, I put up the grading matrix for the lab presentation. So I'm just going to have that myself as I'm watching, and I'll just check off everything. All right, so what are your questions? Trying to be nice and clear so you know what to expect.
Do you want everything stapled together, including the written summary, or that separate along with the workbook separate?
It doesn't matter, just so everything is together. So some people like to put it into a folder. Some people just like to staple it or put it in a binder clip, just so when you put it in the pile, yours is separate from other people.
Okay, thank you.
You don't want or need the clear plastic film things that we trace the things on, do you? Or do you?
I like them all.
All right,
I want to see your handiwork.
perfect.
But I'm not grading you on artistic ability because it's not an art class.
So you want, I mean, I erased the clear things.
Jesse.
It's not part of the grading matrix.
All right, if you don't have the transparencies, I won't take points off. But for those of you that have them, I would like them.
And it says if a student is not ready, what do you mean by that? What does that look like?
I mean, like, look at the schedule. So in other words, if you're scheduled to go at 5 p.m. next Thursday, I want you to, you know, before lab, get all your supplies ready on the side of the gym. And then right at 5, you know that it's your turn and you're ready to go. I mean, obviously it'll take a few minutes for you to get your supplies out, but I just mean if you,
So if we're not ready to go at our time slot, we get a 0 on the presentation part.
yeah, I mean, if you're completely not ready, like if you show up without your supplies, or it takes you 10 minutes to get ready at 5, I just want you to be there and know when it is your time to go. Does that make sense?
Professor, where is the sheet that shows you your time in Moodle for your presentation?
You go up, you'll see one whole section that says final lab project. So we have the instructions, your table, the grading matrix, and then the presentation date and time.
Okay, thank you.
So just know when you go and be ready to go. That's all. I mean, I'm not going to like put a stopwatch on so you have to sprint around, but just come prepared that day. That's all I'm saying. If you're like, oh, I forgot it's my day, well, then you'll get a 0. But I want you all to do well. That's why I'm trying to give you the specific information. Okay,
I have one last question, I think.
go for it.
For the table that has like the antagonist, the antagonist, and the synergist and all that stuff, is it like if we can only find like one muscle that does each, or is it like do you want us to list like 5 or 6 muscles? I mean, I know for the antagonist is only gonna be like 1 or 2, but is there a amount that you really want?
So for the agonists, that's where you might want to list several muscles if possible.
Okay.
So for the agonist in particular, if, you know, because we did this in lab, remember we we made tables of all the motions and what muscles do it. And a lot of times I put a star beside the agonist and then listed below were like helpers. So for the agonist, list multiple muscles that do it. If so, for the others, probably just one will be good.
Okay. Thanks.
I guess kind of going along with that, I'm looking over the grading matrix and it says 20 points per phase for your tables. And I mean, there's a lot of information there. How is that being graded? I mean, if I miss an agonist, am I losing a point? Does that, I mean,
So usually what I,
information there.
sure. Usually what I do is I grade all of them at once. And by doing that, I can be consistent across everyone. If you miss just one thing, I'm not going to take a point off for every one thing that you miss. So if you miss one synergist, I'll probably just correct it. But if you just miss one, I'm not going to take a point off. So it tends to just come like in clusters. So if you miss one or two, I probably won't take any points off. If you miss 3 or 4, maybe I'll take 1 point off. But it's hard for me to give you an exact, but that's why I'll grade them all at once. And sometimes I even make like a little scrap sheet of paper and I'll say like 0 to 5 mistakes, no points off. 5 to 7, 1 point off.
When you
Because
say
there is so much.
mistakes, are you talking about like throughout the whole entire project or like on each table?
On the tables. So it says 20 points for each phase.
Okay.
And I believe that's for all the table stuff.
All right.
So it's not like every individual box is worth 1 point. I didn't have enough points to do that.
Right. Right.
But if I am gonna read each and every box and correct them if needed. So if you are missing multiple, then some points will be taken off. I like all the questions. It means that you're working on it. Makes me happy. We got a small class today. Where is everyone? All right, I'm going to pull up the PowerPoint and then we'll pick up where we left off for the ankle and foot. We were talking about the subtalar joint. Oh, my knee. Okay, here we go. So much good stuff. I don't even know where to start. All right, let me share the screen again. All right, subtalar joint. Okay, here we go. We ended off on Monday talking about the subtalar joint. So that's the joint between the talus and the calcaneus. What type of joint is the subtalar joint?
Gliding.
So the subtalar joint is classified as a gliding joint, and the particular motions that are occurring at the subtalar joint are inversion and eversion. So remember, this is a little bit different because usually when we say a gliding joint, it just glides and we don't really specify a movement, but it's a little bit different here. So subtalar joint between the talus and the calcaneus. It is a gliding joint and it is able to do inversion and eversion. We previously talked about the talocrural joint, The talocrural joint is the joint between what bones? This is our true ankle joint, the talocrural joint. What bones make up the talocrural joint?
Isn't it the talus, the tibia, and the fibula?
That is correct. So the talocrural joint is a joint between the talus and the tibia and the fibula. What type of joint is it?
Hinge.
Hinge, and the motion allowable here is dorsiflexion and plantar flexion. So far we've talked about the talocrural joint, the true ankle joint, joint between the talus, tibia, and fibula. It is a hinge joint, and it can do dorsiflexion and plantar flexion. And then we talked about the subtalar joint, joint between the talus and calcaneus. It is a gliding joint, and it can do inversion and eversion. We ended, and I'm sorry I had to leave early last Monday. I'm here with you the whole time today. We ended off by saying that we combine certain movements, and the combined ankle movements of pronation and supination are actually these joints combined. So what do you need to know? You just need to know that pronation is a combined motion where the foot or the ankle goes in. So if someone has like a flat foot, that is a pronated position. Instead of the foot and ankle being kind of in neutral, the foot and ankle are pushed in. So it's pronated. You don't need to know what specific movements make up pronation. I've listed them here. Technically, pronation is a combination of eversion, abduction, and dorsiflexion, but you don't need to know this. Are you picking up what I'm putting down? Just know that the overall motion is called pronation, and it's when the foot and ankle move inward, down to the ground, like someone that has flat feet. On the other hand, there's a combined motion called supination, where you push your ankle and foot up and out. Think of someone that has a high arch. Their foot is in a supinated position. Just know the overall motion, like a high arch position, moving your foot and ankle out and up. You don't need to know what supination is a combination of. Here it is, but you don't need to know it. In lab this week, we observed, or you will today, we observed the foot and ankle to see if all of you had kind of a neutral foot, a pronated foot, or a supinated foot. Sometimes it's possible just at rest, if your foot's dangling, to, instead of kind of being neutral, sometimes people have flat feet or high arches. Good stuff. Questions, comments, thoughts? Would you say you're living the dream right now in kinesiology? Where else would you rather be at 2:56 on a Thursday afternoon?
Almost anywhere.
Wow, that hurt.
I just hate sitting in front of this screen.
Yeah, I'm done with this online stuff, right? Does anybody else want to boost me up a little bit and tell me it's not so bad?
I would enjoy this much more in a classroom.
There we go. Hopefully this fall, right? Get back to it. All right, good. So you can see on your notes here there's a very important ligament that I haven't talked to you about yet. And it's kind of hard to see on this picture, but it's kind of hard to see the name of the ligament, but I like the picture. This ligament right here is called the calcaneonavicular ligament. So remember, we are on the medial side of the ankle. What is the ligament complex called up here on the medial side of the ankle?
The deltoid.
Right, so on the medial side of the ankle, we have a complex of ligaments that we collectively call the deltoid ligaments. But if we go down a little bit, so I have the name circled, it's kind of hard to read, but it goes between the calcaneus and navicular bone. Therefore, this is called the calcaneonavicular ligament. I'd like you to know this ligament. You should know it's on the medial side of the ankle. You should know that it goes between the calcaneus and navicular, hence the name. And you can see in your notes there, this is kind of called the spring ligament. We're going to talk later today about the phases of gait. And this is a particular ligament that after we flatten our foot during the stance phase of gait, when we push off, that push off is aided by the springiness of this ligament. You don't have to get too much in the weeds about that, but if you just know the calcaneonavicular is the spring ligament, then if I bring up any springing kind of action, which ligament am I talking about? The calcaneonavicular. Good stuff. Okay. I will post this PowerPoint later today. I don't post it earlier because I want you to pay attention, and sometimes there's an answer on here that in a future slide. Okay, so we've talked about the talocrural joint. We've talked about the subtalar joint. Now we're going to move further down the foot. So previously, we've just been kind of in the back, right? In the posterior, the calcaneus and the talus. As we move anterior, we have a series of joints called the mid-tarsal joints. I've circled them in red. Technically, they're called the talonavicular joint, this one, and the calcaneocuboid joint, this one. But you don't need to know them. I'm just pointing out that because these bones are connected, there's joints there. If you're really hungry to learn, the talonavicular joint is a modified ball and socket, and the calcaneocuboid is a gliding joint, but you don't need to know those, if that's okay with you. Yeah? Good talk. Good talk, everyone. Good talk. Then we have the tarso-metatarsal joints. So I would like you just to know these joints as a group. So you should just know that this area of joints is called the mid-tarsal joint. You don't need to know the specific ones, but just know as a group. Right? So the joint between the calcaneus and talus and the next bones is the mid-tarsal joints. Moving more anterior, we have the tarso-metatarsal joints. And the beauty is that because you know your anatomy so well, you already know where these joints are. They're between the tarsals and metatarsals. Duh. These are the metatarsals. These are the tarsals. Technically, well, you can just see joints formed by tarsals and metatarsals. That's all we have to say. Joints formed by tarsals and metatarsals. These are gliding joints. I would like you to know that. These are gliding joints. Okay. Movements allowed, you don't need to know that. Technically, these joints work with other joints of the foot and ankle, but don't worry about it. So just know this is a tarsometatarsal joints and they're gliding. Lastly, as we move even more anterior, we have the metatarsophalangeal joints. This is the equivalent of the knuckles in our hands, but as the name suggests, joints between the metatarsals and the phalanges. Metatarsophalangeal. These are condyloid joints. These are condyloid joints, which basically means that they're like mini ball and sockets. So kind of like the knuckles of your hand, just in your toe. Condyloid joints. So they can do flexion, extension, abduction, adduction. If you have any questions, shout them out. You know the deal. Then we have what we already know from the fingers, the interphalangeal joints. We have a proximal interphalangeal joint and a distal interphalangeal joint. I'm going to point out what I'd like you to know. So just know what the proximal interphalangeal joint is and then the distal. On our first digit, we only have one. Sometimes they call it a proximal, sometimes they call it a distal. But in toes 2 through 5, we have both a proximal interphalangeal joint and a distal interphalangeal joint. But for the toe, we only have one. All of these are hinge joints, just like our fingers, which means they can do flexion and extension. That's all you need to know. Cool. All right, I'm going to keep moving kind of quickly because I want to make sure we get through everything. But that doesn't mean if you have a question, please speak up. Or if I'm going too fast for you, just yell out. All right. You don't need to know these specific degrees. I just like to put them on here for your information. Make sure you know some of these ligaments. I've already talked about them, introduced them. So we already talked about, we have the tib-fib ligaments. Particularly, I'd like you to know the anterior tibiofibular ligament. This is where the high ankle sprain happens. So it's higher because it's at the distal tibiofibular joint. We already talked about, before I do that, sometimes that high ankle sprain is called a syndesmosis injury. You don't need to know that. This is also extra information. Just in case you're wondering, the most common mechanism of injury for getting a high ankle sprain is if your foot gets shoved up into dorsiflexion and eversion. But you don't need to know that. Just know where this ligament is, anterior tibiofibular ligament, and that it is the ligament injured in a high ankle sprain. Good, my friends. We already talked about the deltoid ligaments. These are on the medial side. They are very strong and they are rarely injured. Why is it that we don't see as many injuries on the medial side of the ankle?
Those ligaments are stronger.
That's one reason. What's another reason? What's another reason why we don't see as many medial ankle injuries?
Inversion is more common than eversion.
I think it's the first time all semester we've had two people try and talk at once. That's amazing. I'm excited. Look at the high level of engagement.
Sorry.
Don't be sorry.
I don't know if you heard me, but I said the fibula goes lower.
I mean, the medial tibia comes down, so the medial and lateral malleolus.
I said
Go ahead.
inversion is more common than eversion.
So it mostly has to do with the mechanism. It's much more common for your ankle to roll into inversion. So it's just a mechanism, just like it's kind of more common to injure your medial collateral ligament because it's more common to have a valgus force. Well, here in the ankle, it's more common to have a injury where your foot goes in, and that's going to stretch the lateral ligaments. But that's really extra. I just want you to know that the deltoid ligaments are on the medial side. They are strong and they are less often injured. Cool beans. We talked about the calcaneonavicular ligament being the spring ligament. Just remind yourself that that's on the medial side. In your notes, I give you some extra anatomy, but you don't need to know it. You can see a really cool word there, sustentaculum tali. There's a big bump on the medial side of your calcaneus called the sustentaculum tali, and that's where this ligament starts. But you don't need to know that, the sustentaculum tali. I would like you to know that this ligament has added elastic fibers. That's why it can act as the spring ligament. So in addition to being dense regular connective tissue, like every other ligament, this calcaneonavicular ligament has some added elastic fibers, and that's going to help us have more springing motion during the push-off phase of gait. So the function of this ligament, the calcaneonavicular ligament, is that it gives us more springing action during the push-off phase of gait. Gives more of a springing motion during the push-off phase of gait. Gives more springing motion during the push-off phase of gait. It can also act as a bit of a shock absorber. Because it has that added elastic fibers, even when we are in the stance phase of gait, even when our foot's on the ground, and this ligament stretches, it gives a little shock absorption. So I would list two functions for the calcaneonavicular ligament. Provides more springing as we push off and can be a shock absorber during the stance phase of gait when our foot is on the ground. Good. Now, of course, on the lateral side of the ankle, we already talked about these ligaments that form a T, the anterior talofibular, the posterior talofibular, and the calcaneofibular. So just remind yourself that all three of these are on the lateral ankle. The most commonly injured out of all of these is the anterior talofibular, or ATF. This happens to be the weakest of all the lateral ankle ligaments, and it is injured the most. So the ATF, anterior talofibular ligament, is the weakest, and it is most often injured. The posterior talofibular is the strongest out of all of these. So hopefully you're writing down or reviewing the points that I'm talking about. The PTF is the strongest, the ATF is the weakest and is injured the most. And then just know all three of these are on the lateral side of the ankle. So as Jesse alluded to, and as we were talking about, it's most common when you injure your ankle for it to roll inwards. And when you roll into inversion, you are stretching and potentially tearing the lateral ligaments. Everyone has probably seen or had this happen to them. Yes? Not fun. Okay. So we couldn't talk about the foot without talking about the arches. Let's first talk about their function. So you can see they're written right there for you: shock absorption and spring and elasticity. Have you ever thought about the bones of the foot? Aren't they kind of arranged in a funky way? Like, why do we have this, all these bones kind of small and then connected and then they kind of come up? Well, the reason the bones are put together that way is because we purposely want to have these thick connective tissue arches underneath. Because the foot is the contact to the ground. This is what we walk on. We need to have something strong, but also elastic. And that's what the arches do for us. They are thick, strong bands of connective tissue that are strong. They can hold up these bones, but you also want it to be elastic. Can you imagine just, what if we walked and landed right on our bones? There'd be no give. We would just be banging on our bones, damaging them, having no benefit to help us push off when we walk. So they're strong, they give shock absorption, and then they're flexible so that when we push off, they're a little bit elastic, and that actually helps propel us forward. As an aside, the height of someone's arch is not necessarily indicative of its strength. So just because someone has like a high arch or a low arch doesn't necessarily mean that one is stronger than the other. Here's a cadaver foot. Aren't you glad you came to lecture today? So make sure you know the two primary types of arches that we have. The longitudinal arch, I've put in green here. As the name suggests, the longitudinal arches run from back to front. That's what was shown in these pictures. We actually have a medial and a lateral, but just know the longitudinal arches run from front to back. The longitudinal arches tend to give us more of that support. These are stronger.
I just have a question. Did you say they run from back to front or front to back?
Either way.
Oh, okay.
One's connected, one end is connected in the front, one end is connected in the back. So it doesn't really matter where you say it starts or ends.
All right, thank you.
So the longitudinal arches are strong. They're really more of our support. And then we have a transverse arch. And this runs perpendicular to the longitudinal arch. So it runs medial lateral. And you can see on your notes, this is a little bit thinner, so it's not quite as strong. So this is going to give us more of that elasticity and spring function. So the transverse arch is a little bit thinner, and it's going to give us more of our elasticity function.
What does it mean when someone has a functional flat foot or functional arch?
That means that when they are non-weight bearing, if they're sitting and their leg is dangling, if they're non-weight bearing, they have a reasonable arch. But when they stand on it, their arches flatten out significantly.
And is that just because everything is more lax or not strong enough to support it? Or why does it stay as an arch if you don't have pressure on it, but then actually flatten out?
I mean, a lot of it just has to do with how we're put together. Some people have a high arch in all positions. Some people have a flat foot in all positions. Some people have the functional flat foot where it's high, non-weight bearing, but then flattens out more than usual. Part of it is just genetic. Part of it might relate to any time that you have flatter feet, your structures are more lax. They're more stretched out. Anytime someone has a higher arch, the structures are really tight. So in addition to your genetics, part of it could be due to what you do. So maybe you've been doing activity and for whatever reason, these structures get really tight and it manifests as a high arch. Well, then you might want to try and do some things to stretch it out, roll your foot over top of a Gatorade bottle to try and loosen those tight structures. If someone has a functionally flat foot, maybe they have weaker muscles in their intrinsic foot that are able to hold them up to a high arch when they're sitting, but aren't strong enough when they flatten their foot out. But in my experience, a lot of it is just genetic. And in a lot of cases, people can functionally do very well, even if they have high arch, low arch, Okay, guess I answered the question.
Yes, you did. Sorry.
That's okay. I just want to make sure. What happened to this picture? It got really, okay. Now, in addition to the arches, superficial to them, so the arches are deeper. They're like right up against the bone. Okay, so the arches are deep. They're right up against the bones. Superficial to that, we have what's called the plantar fascia. Here's a look at it down here, and here's a look at it here. So it starts in the calcaneus and it comes up and it fans out. Maybe you've heard of plantar fasciitis, when this can get tight. Issues with the plantar fascia, which is more superficial, issues with their plantar fascia tend to be more related to activity, not as much genetics. It has similar functions as the arches: shock absorption, help with elasticity and spring. Just know that the plantar fascia is superficial and the arches are deep.
What is that yellow portion on the picture there?
So this is trying to represent where
Sorry,
the
at the heel.
here,
Yeah.
that's just fat.
Okay. What I thought.
I mentioned this when we did the knee chapter. Sometimes we have a fat pad, and our biggest fat pad in our body is on the calcaneus. All right. You can see there, and we're going to get into the muscles next. Make sure that you review what muscles make up the Achilles tendon. So we know the Achilles tendon, right? It would continue up here. It's a combination of 3 muscles: gastrocnemius, soleus, and a small one called the plantaris. So just make sure that you know what 3 muscles combine to form the Achilles tendon. All right, I'm going to leave most of the musculature to lab. As we have before, just remember that for each of the muscles listed in your notes, be able to give 1 action, right? For all the muscles given in the lecture notes, be able to give 1 action. Okay. I do want to point out one thing, and I've added this. So on the medial side of the ankle, this is going to be under the posterior musculature. So if you look at your lecture notes, it says letter C, posterior musculature. The muscles listed there, numbers 4, 5, and 6. So posterior musculature, number 4, 5, and 6, these same ones listed in the PowerPoint. One of the easy ways to remember these posterior deep muscles, they're the Tom, Dick, and Harry muscles. See all the good things you're learning? Tom, Dick, and Harry muscles. Because we can use Tom, Dick, and Harry, T, D, and H, posterior tibialis, flexor digitorum, flexor hallucis longus. But anatomically, what's interesting about the Tom, Dick, and Harry muscles, they're posterior deep, so they're deep to the gastroc and the soleus. The gastroc and soleus, their tendon runs here because they're the Achilles tendon, right? The Tom, Dick, and Harry muscles, their tendons run right behind the medial malleolus. So I'd like you to know that. The Tom, Dick, and Harry muscles, they're deep posterior muscles. Know what the Tom, Dick, and Harry muscles are. their tendons run right behind the medial malleolus. So if someone is experiencing discomfort or pain right behind the medial malleolus, it could be related to the Tom, Dick, and Harry muscles. Deep posterior muscles, know what they are. You'll be giving a function in lab of each, but then also know that these tendons run right behind the medial malleolus. Tom, Dick, and Harry. Okay, I've listed here the intrinsic muscles of the foot, but you do not need to know the intrinsic muscles of the foot. Although there are some kind of fun names, right? Abductor digiti minimi, that's kind of a fun name. But you don't need to know the intrinsic foot muscles. Let's talk about some kinetics. We know that kinetics is all about force. So, first things first. Do I have? Okay. This is just in your notes, but I want to make sure that you know it. When you look under kinetics, the first thing there is bony support, and then it talks about soft tissue support. I would like you to know, let me go to a picture of the foot. Okay. I would like you to know under bony support, 50% of the bony support of our feet comes from the rear foot. So half of our bony support comes from the rear foot. And the other half comes from the forefoot. Because it says head and metatarsals. I mean, it's important that we talk about the load distribution because our feet experience a great deal of load. Our entire body weight is on them. So in terms of bony support, if we were to only look at the support given by bones, half of our bony foot support comes from the rear foot, the back, and the remaining half comes from the forefoot. So we don't really get as much support from the middle. Half of the bony support from the rear foot, half of the bony support from the forefoot. Then, in addition to our bony support, we also get support in terms of load from soft tissues. And all I want you to know there is the majority, it says here 80%, the majority of our soft tissue support comes from ligaments. So when we're considering the soft tissue support of the foot, the majority of it comes from ligaments. All right, good. Any questions you're going to ask? You can't be shy at this point in the semester. All right, so if we talk about loads during walking and running, so what are the primary load types on our foot and ankle? Well, it shouldn't come as a surprise. The primary load is compression. Sometimes you might see it called vertical impact. So on this PowerPoint slide, we're kind of breaking it into the top and the bottom. Let me add, let's see, we're going to insert a line. Watch this. There we go. So the top part of this PowerPoint is showing you the primary load that is occurring upon our foot and ankle. Compression. This blue arrow, compression. And what phases of our gait do we experience that compressive force? Heel strike and mid stance. So you should know the primary load, the primary force upon our foot and ankle is a compression force, otherwise known as vertical impact. Boom. And we're experiencing that compressive force on our foot and ankle during heel strike and mid stance. The other type of force that we experience primarily is a tension force, sometimes called a propulsion force. So now we see an arrow going up. As we push off during walking or running, there's a tensile force. And this is occurring during the push-off phase of gait. Of course, we will experience some shear because or torsion, we don't just always walk or run in a straight line. So that does happen, but we're going to focus on compression during heel strike and mid stance and a tension force during push off. Good. And I'm going to post this PowerPoint tonight. Hopefully Oscar won't get in my way. As I've always been doing, I give you some numbers, but you don't need to know these. Just giving you some numbers in terms of running at an 8-minute, 56-minute per mile pace, or a 5-minute, 22-minute per mile pace. These are less than the hip and knee, right? You don't need to know these numbers either. The foot and ankle are going to experience less force. Okay. Make sure you have a look at what's written there in conversion of energy. And I've tried to summarize what's on your notes in this PowerPoint slide. It should be no surprise to us that because of all the elastic components in our foot and ankle, we talked about the arches, the plantar fascia, the calcaneonavicular ligament. We purposely have these arches and ligaments that are elastic. And the point of that not only is shock absorption, but to allow us more momentum during push-off. And we can do that because we're converting energy from when something is stretched into when it recoils. So think about a rubber band. When you stretch a rubber band, you're gathering up potential energy. So when we're in stance, so look at the left side of the screen, when we're in mid stance, the arches, this green line, the arches are stretched like a rubber band being stretched. It is storing mechanical energy. We're also seeing stretch or an eccentric load in our gastroc and soleus. This is storing potential mechanical energy so that when we go to push off, all of that stored energy is converted into active kinetic energy. So in push off, the stored energy that we did have in our gastroc and soleus is now firing, and those muscles will be able to fire with more force. And also that spring ligament, the arches and the black line is a calcaneonavicular ligament. The arches and the calcaneonavicular ligament are stretched in mid-stance, storing mechanical energy, so that when we push off, they recoil, and that gives us more spring, more momentum moving forward. Wouldn't this be a good short answer question? It got eerily quiet out there. You still with me? Okay. Well, I'm going to post this on Moodle, so you'll be able to, this slide summarizes everything I'd like you to know. Okay. You do not need to know the specifics of the lower extremity kinetic chain. Hopefully I eased some of your stress there. You don't need to know the specifics. I'm going to give you some examples, but you don't need to know these specific examples. All you need to know is what is listed in number 1 there on your notes under kinetic chain. Loads are transmitted up the lower extremity. You already know this. When our foot hits the ground, that compressive load is transmitted up to the knee, up to the hip, and up to the lumbar spine. Didn't you already know that? So if we have an injury or abnormality here, it's absolutely going to affect the knee. It's absolutely going to affect the hip and the lower back because they're all connected. This is an example, you don't need to know it, but if someone is overpronated at the foot, has flat feet, if someone is overpronated at the foot, in order to compensate, the tibia tends to internally rotate. And you can see this person is more bow-legged. And that's actually a compensatory mechanism to try and compensate for the flat feet. So you don't need to know any specific examples, just know that everything's connected. In lab, you're going to be doing an assessment of yourself and others. Okay. Perfect. So I'm going to skip ahead in the notes. We have 2 main things to talk about, and we're going to get through them quickly here. If you go a little bit further in your notes, under injuries to the ankle or foot, alignment abnormalities, you can see shoe selection. I mentioned this in lab on Monday, and I'll mention it again today. Pes planus is the same thing as someone that has flat feet. Pes planus is the same thing as flat feet. If someone has flat feet, you should get a running shoe that is sometimes called motion control or stability. I've given you some examples here of models of sneakers. These are probably a little outdated because I did this a couple years ago. But the idea is if someone has flat feet, you want a rigid shoe. So I'd like you to know that if someone has flat feet, usually it's best to have a rigid shoe. Their foot is so stretched out, it's too lax, it needs some rigidity. On the other hand, pes cavus is a high arch. High arch people have really rigid, tight foot structures. So if someone has a really tight arch, you actually want a flexible shoe. This isn't always the case, but if you go for like to Fleet Feet for a shoe fitting, this is what they're going to lean you towards. Whether it feels good for you or not is up to you. If someone has a neutral arch, well, then there's certain models that are more neutral, not too rigid or too flexible. So if I ask you on the exam next Monday, if someone has flat feet or pes planus, what type of shoe would be best for them? You're going to say a rigid shoe. If I ask you what shoe type is best for someone that has high arches or pes cavus, you're going to say a flexible shoe. Are you with me? Okay. These are old examples. Don't worry about that. Okay. We're almost done here. So what do you need to know? Again, we skipped ahead to injuries to the ankle and foot. You should know what pes planus, pes cavus, and neutral mean. The only other one that I'd like you to know on that list is hallux valgus. The only other one on that list that I'd like you to know is hallux valgus. That just means that you get a calcification or a callus here, a bunion, in other words, and it can make the toe move laterally. So it's really a bunion forces the big toe to move laterally. Hallux valgus. Stay with me. I know we're almost done. When you look under ligament sprains, the only two things I want to point out that I already have pointed out, the only things you need to know for the ligament sprains is that the ATF is most commonly sprained. That's the anterior talofibular, most commonly sprained. And then just know that the high ankle sprain involves the anterior tibiofibular. Those are the only two things you need to know under ligament sprains. That ATF is most common, and that high ankle sprain involves the anterior tibiofibular ligament. You don't need to know anything about stress fractures. I've got extra information on this PowerPoint, but you don't need to know it. Last thing, I've put together these two slides, slides 48 and 49. These are what I'd like you to know. So let's just go to the summary table. Look, I've put it all together for easy study. You should know these 4 phases of gait. There's the swing phase when your foot is in the air. And then the stance is when your foot is in some contact with the ground. We have the heel strike, which is, you know, when your heel hits the ground. Mid stance, when your foot is level with the ground. And then push off or toe off. So you should know these 4 phases of gait. And then what I have in bold, which is a combination of what we've covered in lecture and what we'll do in lab this week. In lab, we talked about this. During the swing phase, what are the agonists? What muscles do hip flexion? You already know that, iliopsoas rectus femoris. The adductors are also contracting to keep your leg in the sagittal plane. We already know at heel strike, it's a primarily compressive load. One thing we'll talk about in lab is that your tibialis anterior contracts eccentrically to control the deceleration of your foot. We already talked about at mid stance, the arches are stretched, they're storing mechanical energy. We talked about there's eccentric tension in the gastroc soleus. What I'm adding that we'll talk about in lab is the gluteus medius is contracting to keep the pelvis steady. For push-off, we already know it's a tension force. We already know there's going to be stored energy released from the arches. The gastroc and soleus are contracting, and the calcaneonavicular is springing to give us elasticity. I can't make it clearer than this, folks. Combination of what we've already talked about here in lecture and some of the other pieces we'll add in lab. I'm going to post this right now on Moodle. I am a rock star because it is 3:49. Boom. That's all I have. I will stick around to answer questions, and then I will see a lot of you in lab in a few minutes.
I just have a question real quick.
I'm listening.
Okay. Sorry, everyone was leaving. I didn't know. So I sent a message in the chat in the beginning of lab. I don't know if you saw it, or class. And then I just sent you an email. I got my vaccine shot 2 days ago, and I had a reaction to it that was pretty horrible. So I sent you an email. I haven't missed a lab yet, so I don't really know how it works if you do.
So yeah, what I'll do, Brendan, no problem. I'm going to email you the makeup.
Okay.
And then
Okay.
it'll say exactly what you need to fill out. And then as you have questions, let me know.
Okay.
And
All right. Yeah, I'm sorry I didn't get back to you. I've literally been sleeping for the last 2 days. It's been pretty rough.
That's okay. I'm glad you were able to be here for lecture and feel better, okay?
Thank you.
All righty.
All right. See you later.
See you later.